Magdalene. All right, so any questions from last week? We started our behavioral talk. We'll finish that up today, and this will be the end of lecture material for the first test, and then your test will be next week. And I got everything all posted up for the next section, so you can download that stuff whenever, including the prescription assignment for the next section, so don't forget to turn that in. Otherwise, your grade will suffer. It's not what we want around here, right? Okay. So no questions from the first half. You guys feel pretty good on depression, and what else we talk about? Bipolar disorder. Pretty comfortable with those medications. You will at least by next Friday, correct? Sure hope so. I sure. Anywho. So let's talk about antipsychotics. So you probably think many of your professors probably need these, but we'll get into kind of where they're used, kind of the drawbacks in a lot of cases, because again, very similar to medications we saw used for like depression. One of the big drawbacks is the side effects. And that's usually what's going to predicate switching over to a different agent or trying something else for your patients. It's not always going to be lack of efficacy, but more often that side effect profile. Now looking at schizophrenia, you haven't really talked about that at all yet, right? So you're still waiting on the behavioral section. So anywho, there's probably a lot of different etiologies here. There's definitely a genetic component, because we know people who have first-degree relatives who have schizophrenia tend to also be at risk for schizophrenia as well. There's probably some nature and nurture kind of goes into this. Some thought to things like glutamatergic toxicity at birth, maybe due to things like hypoxia. But anywho, lots of different things that go into it. But basically, with schizophrenia, and can anyone describe schizophrenia? What is that?
Is it a chemical imbalance, or is it just a myth?
Well, we treat it as a chemical imbalance, just like we did for depression, right? We fix the serotonin levels, even though it takes 6 weeks to work. That's not the actual issue, but there's probably some downstream stuff. So certainly there's some, we treat it as such, because that is how we're, modifying these things with drugs, is fixing these imbalances, so to speak. If you had to describe a schizophrenic patient, how would you describe them?
Out of touch with reality.
Good, absolutely. So they have an out-of-touch sense of reality. They may have an altered sense of reality compared to other people. You're going to find that we're going to break these down into 3 main categories of symptoms. You're going to find people will have what we call positive symptoms. These are things that are going to be there that actually are not there. So these are things like hallucinations, primarily of an auditory nature in a lot of cases. So they're hearing voices that are telling them to do things. A lot of these delusions of grandeur, like me coming in here thinking you guys want to hear from me every single week. It's a delusion of grandeur. Right? They're going to have negative symptoms, which are going to be things that should be there but are not. I'll cover this in a different slide. But these are things they don't really find pleasure in things that they should otherwise. They don't really have motivation to do things. So you're going to find things like compliance with medications is going to be really poor. The ability to keep a job, hygiene goes kind of out the window with a lot of these patients. That'll be a big issue. And then there's some cognitive symptoms that come about. So maybe have impaired memory, impaired attention, things like that. So that's important because when we're looking at the different medications we're using here, they're working on different parts of the brain essentially. And I'll show you a slide that kind of makes this a little bit more clear. But basically, what we're thinking is that there's a big issue with dopamine receptor function. Okay, so dopamine is going to be one of the big neurotransmitters that we're going to be affecting when we're using antipsychotics. So for depression, the big neurotransmitters were what? Serotonin, and secondarily norepi. Remember, so the TCAs affect norepi, or SNRIs affect norepi. Here, dopamine is going to be the big thing. So you're going to find that there's hyperactivity in some parts of the brain. I'll show you a slide that kind of illustrates this. There's going to be hypoactivity in other parts of the brain, and that we think those are responsible for those different kind of types of symptoms, as we'll see here. So for instance, if you have hypoactivity in the frontal cortex, they're thinking that leads to a lot of the cognitive decline, and then also some of the negative symptoms that happen with these patients. And then having hyperactivity in the mesocaudate are probably likely to see some of these positive symptoms, like some of the hallucinations and things like that. So there's also some thoughts like glutamate being responsible for some activity here, but more importantly for our purposes, and especially when we talk about the drugs here, there's going to be first generation and second generation agents. The second generation agents are going to affect serotonin. Specifically, they're going to be agonists at these serotonin. That they're going to be serotonin antagonists at the frontal cortex. And so again, when we get to those specific agents, that'll become more clear here in just a second. So looking at this, and it looks pretty confusing, but basically you're going to have these dopaminergic neurons. They're going to have these different projections. So for instance, this one here is projecting down to the nucleus accumbens, kind of mesocaudate, and then you're going to have here these other projections to the frontal cortex. And so having things like hyperactivity here in the nucleus accumbens is where we see things like hallucinations or have these delusions of grandeur. However, in the frontal cortex, you're actually having hypoactivity, and that's going to be causing some of these negative symptoms. And it kind of makes sense when we talk about serotonin having a negative effect effect here, because if you have too much activity, this will actually inhibit dopamine release. And so we're going to see that by affecting this, we can actually affect dopamine release in the frontal cortex. Again, this will be more clear when we get to the actual medications, but this is kind of the basis we're going to be working off of when treating schizophrenia. So, of course, the pictures always screw things up.
I think it's a PowerPoint thing, because mine doesn't.
I believe it's a PowerPoint thing, because my computer can run games at 60 frames a second at ultra detail. It looks great,
Fancy.
but PowerPoint's little picture on the slide brings it to its knees. I don't get it, but
What's the dopamine effect? Is it always affect acetylcholine, or is that just not specific?
yeah. So when we talked about Parkinson's, that's going to be important when we were talking about some of the side effects we're going to run into. Because what was the issue with Parkinson's? What is Parkinson's basically? Loss of dopaminergic, yeah, loss of dopamine, dopaminergic neurons. We're not having activity of dopamine. We're going to find a lot of these drugs here, especially the first generation agents. They will block the activity of dopamine, which is what side effects would you expect? Blocking activity of dopamine might induce Parkinson-like symptoms. Absolutely. So you can see Parkinson-like symptoms from these medications, right? And so acetylcholine is going to play a role with this as well, especially when we're talking about, because we said when you have a lack of dopamine, what happens to acetylcholine activity? Goes up, right? That's why you have that tremor that happens, that seesaw effect. You're going to find that when you have certain side effects from these dopamine blocking drugs, you have that acetylcholine activity. The way to treat that is again with an anticholinergic to try to bring things back into sway. So we'll see that in just a few minutes here when we get to the medications. And as we mentioned, they're having these positive symptoms, hallucinations, delusions. You might find their affect to be, flat, inappropriate, or pretty labile in a lot of cases. We see this from the emergency medicine standpoint when we have a lot of these patients who are coming in with kind of acute psychotic episodes, and they can become very dangerous. They can become very aggressive, not only to themselves but also to others. And so these patients can be kind of a management kind of issue because again, you don't want your nurses getting swung at by these patients or things like that. And they're also prone to things like overdose and whatnot and substance abuse. So these are big issues we run into from the emergency medicine standpoint. So we'll see some drugs that can be used to help manage that. They oftentimes have a hard time thinking that there's even anything wrong with them in the first place. Usually like when you have depression, like once you're kind of told what it is, like you can kind of make some peace with that and you can kind of say, okay, yes, I have depression, I should probably get treatment for it. However, these patients, they may not really have any sense that anything is wrong. They may have hallucinations that are telling them, yeah, nothing's wrong, they don't have to take these medications, and compliance is a big issue. So we're going to see some ways we can get around that. How would you enforce compliance when a patient doesn't want to take a medication orally? You do things like give them IM medications that stick around for a long time. So we'll have some medications that come in kind of an oil sort of base. You inject that into the muscle, and that'll be released out over the course of, say, 3 months or something like that. And that can be a way to kind of enforce compliance for some of these patients. We'll look at a few examples of that. So as I mentioned, those different types of symptoms, the positive ones include things like, paranoia, you think someone's out to get you, hallucinations, as I mentioned. The negative symptoms are things that should be there but are not. So the flat affect, the alogia, anyone know what that is? It's the inability to kind of come up with words to try to express themselves. So the loge, kind of coming from that base, you come for words. Anhedonia, anyone know what that is? A lack of pleasure in things or finding pleasure in different things. So if you used to like to go golfing, now all of a sudden you don't like to golf anymore, that would be anhedonia. And avolition, kind of hard to initiate things. They can't really have a lot of motivation to do things. And those cognitive symptoms, a lot of impaired attention and memory. Think of the negative and the cognitive symptoms kind of going hand in hand because a lot of that comes out from that hypoactivity of dopamine in the frontal cortex. Positive symptoms are more going to be the dopamine hyperactivity. Okay, which one of these do you think would be kind of more dangerous in the acute phase? Yeah, probably the positive symptoms, right? So again, if they're very paranoid and they're having these kind of aggressive, obviously if someone's has avolition and they're not really looking to do anything, they're not really that dangerous, right? They're just going to be sitting around like a bump on a log. Those are the symptoms we're oftentimes trying to treat when patients are coming in for acute psychotic episodes, things like that. So these are the more kind of dangerous symptoms in the acute phase. However, obviously we want to be able to manage all of these. That'll be important because when we're looking at the different antipsychotics, the first generation agents really only treat these positive symptoms. Okay, the newer ones are going to be able to treat more of all three of these categories essentially. So our desired outcome, obviously pharmacotherapy is super important for these patients. Obviously you'd like to institute other non-pharmacologic therapy like cognitive behavioral therapy, things like that. However, once you discover someone has schizophrenia, you really want to treat it early and aggressively because that first 5 years is where they tend to have kind of the most deterioration in their kind of psychosocial sort of standpoint. So you want to make sure you kind of get them on a good treatment plan. You need to try to target the symptoms that are most bothersome for the patient, right? So if they're having a lot of positive symptoms, you need to manage that. If it's an issue of the cognitive symptoms, try to target those things. And you need to give it, roughly 3 months to really see how the patient's going to respond to it. You're going to find that, you'll be able to deal with a lot of things like positive symptoms pretty quickly, but you need to see how the patient's going to respond from a side effect standpoint. You're going to find a lot of these drugs have metabolic complications associated with them, so you need to give it some time to see how the patient's going to fully respond to that. So we want to minimize the amount of side effects we're going to see with these, and unfortunately a lot of these medications are very prone to having side effects. You got to be careful with those. And then we'd like to decrease rehospitalization. So the more kind of stable we can get them on these medications, the less likely they are to have an acute episode, have to go into the ER, have to get admitted to the hospital, and all that. So if we can avoid that, it's going to be the best possible outcome for them. And then obviously minimize costs and try to get as good a compliance as we can. All things are going to be big issues with these kind of patients. So the first generation antipsychotics, their main mechanism of action is they're going to be blocking dopamine 2 receptors. Okay, so this is going to be having the biggest effect on those positive symptoms, because we mentioned that's dopamine hyperactivity in that music caudate, in that nucleus accumbens. And so we can block this and hopefully deal with those positive symptoms, right? You're going to find that most of these drugs are going to have similar effects to the TCAs, in that they're not going to just affect one type of transporter or one type of receptor. They're going to have multiple activities. So like TCAs, remember, they affect reuptake of norepinephrine and serotonin, but they also had anti-muscarinic activity, and they had anti-alpha-1 activity, and they had different effects that led to more side effects. They don't really have anything to do directly with their therapeutic effects, so you have to keep those side effects in mind, and we'll look at some examples of that. And there's some tables that will kind of make more sense of this as we go along. So again, if you were to imagine the first generation antipsychotics, they're basically going to be blocking dopamine activity here in the nucleus accumbens, and that should help to decrease those activities of those positive symptoms. Next time I'm just going to take these out completely. Just look up a picture. Google it. But basically what you're going to find is that as far as from a side effect profile, like the Parkinson-like symptoms are going to be a big thing we're going to be monitoring for. And you're going to find there's kind of a gradation here where you're going to have some drugs that are very, very potent at blocking dopamine 2 receptors, and that's really their main activity, and that's the main side effects you're going to see. And there's going to be some that are going to be less potent at doing that, but they are going to have more things like anticholinergic activity. They're going to have more alpha activity. And so we're going to see that depending on which one you're looking at. I'll give you a few that I want you to have memorized for testing purposes. I have an idea on that kind of spectrum what type of side effects you're going to expect from, say a chlorpromazine versus something like a haloperidol. Has anyone seen that movie A Beautiful Mind? The Russell Crowe. That's a really good example of. I think it's a good kind of showing of someone with schizophrenia, how he's having a lot of these positive symptoms, and then seeing the effects of going on a drug like chlorpromazine and things like that, and see just the major side effects and how it kind of can really be detrimental to the patient. Overall, it's probably an improvement because they're not having hallucinations and things like that, but they have a lot of other negative side effects. So other things you're going to see when you have decreased dopamine activity, that will also cause an increase in prolactin levels. And so anyone know what prolactin does? Yeah, it helps with things like milk production, like pregnant or breastfeeding women, things like that. But you're also going to see other effects like things like gynecomastia, which kind of makes sense. If it's trying to help out with breast milk production, it can stimulate growth of that tissue in men. And then you can also see some menstrual irregularities. That's one thing to consider with these antipsychotics. That's due to the dopamine antagonism. You're also going to find that with that dopamine antagonism, you'll have some increased acetylcholine activity, right? Because again, this is just like Parkinson's, where you lose that dopamine activity, more acetylcholine is going to happen, and that's where we're going to see some of these side effects coming from. Now, has anyone heard of extrapyramidal side effects, or EPS? This is a main set of side effects you're going to see related back to this dopamine antagonism. Okay, so these are important things to remember. Basically, what you're seeing is that the most common things you're going to run into are these going to be Parkinson-like side effects, where you can see in some severe cases where, especially as the doses continue to escalate, you're going to have this catatonia, you're going to have this motor rigidity. They have a difficult time initiating movements, just like a Parkinson patient does, right? And you'll also get some of that tremor due to that acetylcholine activity, right? So all of that is very similar to what we saw with Parkinson's. And again, because this is like a drug-induced sort of Parkinsonism, you can see with these patients. The other one of the big things you can see is called dystonia. You can have acute dystonias that occur where basically you'll have kind of involuntary muscle contractions, usually things like the upper extremities of the face and the neck, where it'll be very uncomfortable for the patient. They'll have a hard time kind of relaxing those muscles until the drug kind of wears off. So a good example of this, one of my attendings in fellowship, he had this story where this family, they wanted to all go buy street Valium. Basically, they're buying Valium off of the street from a drug dealer. Valium being a benzodiazepine. We'll talk more about that in a second. But what would you imagine that a benzodiazepine would do to muscle contractions. Yeah, usually relaxes, right? Usually we can use them as muscle relaxants in a lot of cases. These patients came in, and it was like, I think it was a husband, wife, and a son. They all came in, and the son was like in his 20s or something, so he was old enough to know better. But they all came in, and they had these like kind of acute dystonias, where basically their upper limbs were contracted, their faces were contracting, the neck muscles as well. And so they're like, well, that doesn't make sense. Like, they said they'd taken Valium, but they come with these acute dystonias. So they said, this looks more like one of these antipsychotics. And so they had some of the pills left over, and they did an identification. They found that the Valium that was available on the market was very similar in appearance to haloperidol. Haloperidol is going to be one of these antipsychotics that's very, very likely to cause an acute dystonia. So even though they thought they were doing Valium, they actually had got haloperidol instead, and comes up with these dystonias. We'll talk about how to treat that in a little bit, but just be careful. And again, don't buy drugs off the street, or at least identify them beforehand. If you're going to do it, you can call the poison centers now. And always have people that call up and they're like, oh, can I get this pill identified? I found it on the ground. And I'm like, oh, okay, you found it on the ground, identify it. And it's like, oh, weird, it's like an Oxy 80. That's weird, you just found that on the ground. It's, Okay, whatever you say. Anywho, the other two big things you can see from this this antagonism of dopamine, one's called akathisia. We already kind of mentioned that with the antidepressants. And what did I say that was? How would you describe akathisia? Yeah, so that's kind of one of the side effects of that, where they have a little bit more energy. But again, think about like they're uncomfortable in their own skin. I heard my wife described it as ants in the pants, essentially, where you just like you want to get up and walk around and move, like you just don't want to sit down and be still at all. And so that's another big side effect you can see with that, a lot of pacing, shuffling feet, things like that. And then one of the long-term effects, so the acute dystonias, the Parkinson-like side effects, the akathisia, those are kind of acute issues that you run into with these drugs. The long-term thing that we worry about, and this is why a lot of patients, we don't like to stay on these first-generation antipsychotics for long-term, it's called tardive dyskinesia. Okay, it's a long-term thing that happens, and basically what happens is, when we mention with antagonists, when you're blocking receptors, what do the receptors do in response to that to try to maintain homeostasis? Do they upregulate? Do they downregulate? They should upregulate, right? Because again, they're sensing there's not enough dopamine activity, so they want to send more receptors out to become more sensitive. You get this hypersensitization that occurs, and basically what you find is that you get this either slowly reversible or completely irreversible effect, where basically they're going to have this really sensitive dopamine activity. They have like way too much kind of involuntary movements that occur here. So they can have this kind of chewing, kind of licking sort of movements that occur, and again, this is totally involuntary. They're going to have tongue protrusions and limb movements. And so it's seen more with these kind of really potent dopamine 2 receptor blockers for long-term therapy, high dose therapy. You can look up some videos online and find some really good examples of what tardive dyskinesia looks like. And it's a big hit to their quality of life for these patients. And so for a long time, when all we had was the first generation agents, this was just kind of a bygone conclusion that, yeah, you're probably going to have tardive dyskinesia at some point. However, with the newer drugs we have now, we can avoid a lot of this. So just keep that in mind. However, we still use these first generation agents, especially on the kind of the acute phase. We'll look at some examples of when we use those. Now, it's important to know this is not going to be treated like a dystonia. So when you look at the treatment for an acute dystonia, this will not also treat tardive dyskinesia. So really the only thing you can do with tardive dyskinesia is stop the offending agent and try to see if any of it reverses on its own, but there's really no good treatment for it, unfortunately. Some other effects you can see, especially from kind of lower potency D2 blockers, are going to be alpha-1 antagonism. This can lead to a lot of postural hypotension, some dizziness, some reflex tachycardia, so you can see that, and then a lot of antimuscarinic activity. So we talked about the mnemonic for antimuscarinic effects. What is that? There's a beat, dry as a bone, night as a hatter, hot as Hades, blind as a bat. Did you say that one? I'm trying to remember. This is the fifth one. Huh? Anyway, you guys know what it is. But also the tachycardia is kind of seen with that as well. So again, what you're going to find is that those agents that have more antimuscarinic activity, those are actually protective from some of those Parkinson-like effects. If I only had pure dopamine 2 receptor blockade, you're more likely to see those Parkinson-like side effects. But by using something that's going to have more antimuscarinic activity, which makes sense, because how do we treat some of those Parkinson-like symptoms for Parkinson's patients? Give them an anticholinergic, right? Because we said by blocking dopamine, you have more acetylcholine activity. We're trying to bring that back into balance. And so some of these drugs can kind of do that themselves a little bit, and that mitigates some of those side effects. So we'll look at that when we get into the actual tables. We'll see how that kind of makes sense based on receptor activity. So there are also going to be some histamine receptor blockades, so you can see some sedation associated with these. A lot of these medications are very, very sedating. A lot of times if you have like an acutely psychotic patient coming into the ER, do you think you can get like an IV on someone like that? They're trying to fight you. No, you can get IM though in a lot of cases. You can basically just kind of jab and hold them down, jab them with a syringe, and get some medication into them. And so the antipsychotics we'll use for them are very, very sedating, which is good because then they finally get chilled out somewhat, or they start to sleep, and then you can get them in restraints. You start an IV, do whatever you need to do if you need to get them to a CT or whatever. That's a lot of the kind of emergency use we'll see for some of these first generation agents. And then in addition, there's going to be some cardiac effects. Again, you're going to see this more kind of in overdose situations, or if you have multiple medications, it can stack up and do the same thing. So you can see things like QT prolongation, tachycardia, and even some of them will have some sodium channel blockade that can predispose you to some ventricular arrhythmias. So just keep in mind there is some cardiac conduction stuff. You want to check the EKG baseline typically before you start prescribing these for the long term. Okay, has anyone heard of neuroleptic malignant syndrome? So this is something seen especially with these really potent dopamine 2 receptor blockers, and the two big ones we're going to focus on for this is going to be haloperidol. Has anyone heard of haldol before? Yeah, certainly if you worked like in ER or EMS, you probably heard of it before. And then flufenazine is another one, not used quite as commonly, but it's another really high potency blocker. Basically, this is a potentially life-threatening condition. Has anyone heard of malignant hyperthermia? Seen like with surgery sometimes, or certain paralytics. Basically, we'll learn about that in like a surgery section later on. But essentially, neuroleptic malignant syndrome is seen as this dopamine 2 blockade, and you get this lead pipe rigidity that happens here. And so your muscles basically get overactivated. They get very, very tight. The patient cannot relax their limbs. And essentially, when you have that muscle contraction occurring for a long period of time, what do you think that does to the muscle? Well, it's eventually going to, and again, this is more like an acute emergency sort of setting. They get very locked up, all that muscle contraction, all that energy, you run out of, you can't really do oxidative phosphorylation appropriately, so you switch over to using anaerobic metabolism. You get very hot, you get a lot of acid, and that muscle starts to break down. So you can see things like rhabdomyolysis occur here. That myoglobin, as it spills out into the kidneys, can cause to precipitate, cause renal failure, all kinds of bad stuff. So you have to be very careful with this. If a patient, is getting, haloperidol, all of a sudden they say, yeah, I feel really, really tight, I can't relax my limbs. That's a bad sign. You should be really cognizant of that and watch out for it. We also see a lot of hyperthermia, hypertension, and altered mental status. So again, this looks a little similar to serotonin syndrome, which we talked about last week. However, this is usually going to be much more severe from a muscular standpoint. You're going to see a lot more kind of locking out of the limbs. Usually, like serotonin syndrome, you see more like kind of myoclonus. Not nearly severe from that standpoint. But you will see altered mental status. You will see hyperthermia. So they can be very similar, and that's why you have to look at the med list to see what they're on, what they were taking, in order to kind of clue you in to see like what could it possibly be that you're dealing with, right? Because the treatment is going to be different. Because with serotonin syndrome, there's too much serotonin activity. We use like a serotonin blocker like cyproheptadine. Here, the issue is dopamine. So you would treat that differently, as we'll see in just a second. So the ones I have in green here are the ones I want you to be familiar with for the test. Again, there's a lot of these that are available that are out there, and again, their use has gone down somewhat, mainly due to things like side effects and due to the fact with the second generation antipsychotics that are available to us. But things like chlorpromazine or thorazine, this one is still used occasionally. Actually, one unique indication you might see it used for are people who have chronic hiccups. If you can't get rid of a hiccup for whatever reason, you find that things like chlorpromazine actually has decent effects to inhibit that. Can't give you a good mechanism for why that is, but if you have chronic hiccups, which some people do, you get thorazine, and that sometimes will fix it. Prochlorperazine or compazine is another one we use a lot for. Sometimes we'll use it for migraines. So you may see that, and again, because these are dopamine blockers, similar to, you remember any like antiemetics that we use that were dopamine blockers? I'll mention here in a second. Remember metoclopramide or Reglan? That one is actually a dopamine 2 receptor blocker as well, and that's why we mentioned like when you have chemotherapy patients back before Zofran was around, they'd have to receive huge doses of metoclopramide or Reglan, and that would actually cause some of these Parkinson-like effects. It would cause tardive dyskinesia for some of these patients. But again, no one likes to vomit, so it's kind of worth it for them in the acute phase. But a lot of these have antiemetic sort of properties to them, and so sometimes we use compazine for that purpose. Other big ones, flufenazine and haloperidol. These are very, very potent D2 blockers. And it's not important to memorize every single plus that are in these boxes, but typically when you're dealing with something that's very high potency dopamine blocker, you'll find kind of lower activity on blocking muscarinic receptors or alpha-1 receptors, right? However, when you're dealing with something like chlorpromazine, which has relatively low affinity for the D2 receptors compared to something like haldol, you're going to find it has much more muscarinic activity, much more alpha-1 blocking, histamine blocking effects. And so again, it's kind of a gradation there where you can see more risk for things like, or acute dystonias with haloperidol. However, sometimes you can avoid some of that with chlorpromazine because even though you're blocking dopamine, you still have that antimuscarinic activity that kind of prevents that somewhat. So again, every patient will respond a little differently to these medications, but those are the big kind of differences between these different first-generation antipsychotics. Okay, basically the receptor activity. But just know really that fluphenazine and haloperidol, those are the two big high-potency D2 blockers. Those are the ones you're more likely to see neuroleptic malignant syndrome, more likely to see those acute dystonias from it, right? But any of these agents can do it. And actually, I had one patient, we had to call to the poison center. It was I believe it was a 1.5-year-old, and the mom, who unfortunately did not win Mother of the Year that year, decided doesn't want to hear the baby anymore, and said, I'm just going to go into my room, lock the door, and be done with it, and left a bunch of medications out. And so, has anyone heard the term a piece of the tonus? If you Google an image of it, you'll see this old painting of a guy who's got really severe back arching, and this kid had gotten into one of the mom's medications, and all of a sudden had this really bad back arching. The kid was in immense amount of pain, screaming like crazy. EMS got called in and was bringing him in. They were like, well, what the heck could this kid have gotten into? And it seemed like an acute dystonia. And so when you got the mom's med list finally, turns out she had been on, I'm trying to think, which one was she on? She was on this thiothiazine, this Navain. And so once we got the history of that, we said, okay, well, now we know what it is. We know it's an acute dystonia related back to this dopamine receptor blockade. Now we know how to treat that. And we'll talk about how to treat those acute dystonias in a second here. And actually, that was an interesting case because anyone heard of the drug called Nubain? Nubain is actually an analgesic. It's actually something more like an opioid. And so initially when we got the call, EMS was getting information from the mom, and they thought they heard Nubain, and that got communicated to us. So you guys ever play telephone in elementary school? The same thing happens when you're dealing with medicine all the time, right? So the patient tells one person one thing, and they tell the doc that, and they tell the consultant that, and then all of a sudden it gets totally lost. So we were thinking, well, Nubain, like this kid's not sleepy, like the kid's not respiratory depressed. He's having this acute dystonia. Like what the heck's going on? Finally figured out, okay, it was Navain, not Nubain, right? That's why it's important to, if you can talk in generics, that's usually going to be a little bit good to avoid some of this kind of mix up. So anyway, just a little medication safety point there. I think this slide's a little bit better from a side effect standpoint to kind of delineate between some of these different agents and some of their side effect profiles. So we mentioned low potency agents like chlorpromazine have high amount of sedation because they have a high histamine receptor blockade. You have relatively low amounts of EPS, so those extrapyramidal side effects compared to your high potency agents, more anticholinergic effects, more orthostasis due to alpha blocking effects. And then compare that to your high potency agents like your fluphenazine and your haloperidol, relatively low amount of sedation compared to the high amount of EPS that are going to be getting with that, right? So again, keep in mind that the more dopamine 2 receptor blocking potency it has, the more likely you are to see the EPS symptoms, okay? And we'll talk about atypicals here in just a few minutes, but you'll note here that they have a very low amount of EPS, and that's going to be related back to their mechanism, which we'll see in just a few minutes. So first generation agents, really good for treating positive symptoms, but the side effects are often the big thing that leads to discontinuation, especially over the course of years when you worry about things like tardive dyskinesia, right? Because that is an irreversible phenomenon. That's why a lot of people go on drug holidays. Has anyone heard that term before? That's not like where you take a holiday to go somewhere to do drugs like Amsterdam. That is something where you actually take a break from your drugs for a period of time. And this is one of those sets of drugs where you might do so, right? So you would say, okay, let's try coming off the medications for a period of time, try to kind of let you go without the side effects a little bit, and then kind of go back on it later on. But and you would select the agent based on the symptomatology. So if their issue is really those positive symptoms, like going with a more high potency agent's a good bet, versus if their issues were more kind of negative or cognitive, maybe something like a little bit more low potency agent would be better. Nowadays, though, we have the atypical agents, which are going to be better from that standpoint, as we'll see in just a few minutes. So looking at the EPS, these dystonic reactions, this akathisia, we actually will treat this with the anticholinergics, okay? So that makes sense based on our talk with Parkinson's, where if you're blocking dopamine, you're having too much acetylcholine, you can bring it back into balance by having an anticholinergic added on board. And so usually you're going to use first-generation antihistamines. That's probably the most common thing. So for that baby that had the Navain, that thiothiazine they got into, having that really bad dystonia, certainly we gave them some benzos to try to have work as a muscle relaxant, but the big thing we did to fix that issue was give them Benadryl or diphenhydramine. Using the anticholinergic properties there will help to relax those muscles. It'll help them kind of get back to baseline, and then you would keep them on that for like 24 or 36 hours or so, and then they can come off of that, and they should be kind of back to normal essentially. Other agents you may see being added on, and some patients will be on this kind of daily. So if they have a history, and again, we'll use first generation agents typically if like patients fail the second generation, this is like the only thing that's kind of keeping them kind of stable. They might be on a first generation for a long period of time, and we'll have to give them one of these every single day in order to help prevent some of those symptoms from occurring. So the two other big ones you may see are called trihexyphenidyl or Artane, and then benztropine or cogentin. Those are probably the most common ones you'll see being used. Less antihistamine activity, but definitely has some anticholinergic activity there. It'll help to balance that out. So someone had to be on Haldol on the long term, you can give them benztropine daily, and that would help to mitigate some of the side effects, right? Alternatively, I could just put them on a first generation that had more anticholinergic properties to begin with, something like a chlorpromazine, and hopefully you mitigate some of the side effects. But some people may be more sensitive to that dopamine blocking effect than others, and so you have to kind of play by ear and see how the side effects kind of work for them. That makes sense?
So when you're using it to kind of counteract it, are you using it to get them off of that and then pick something better, or you're just going to say, okay, you need to take Benadryl every day?
Yeah, so it depends on the patient. So for instance, in the case of that accidental ingestion, they only need it for like 24 hours and they're back to normal, right? For someone who needs to be on one of these medications, right, if they kind of failed everything else and they're like, okay, haloperidol is the only thing that's going to work for you, then they may need to be on this every day, right? So again, ideally, you'd like to use fewer drugs if possible. And so again, the second generation agents have mitigated a lot of use of this stuff. However, some patients are only going to really respond to Haldol. They may only respond to flufenazine, things like that. So they may need these daily in order to help stave off some of those symptoms. Yep. Okay. And again, benzos are really good as a backup because again, they act as kind of a general muscle relaxant, general CNS depressant. Those can be used as well. As I mentioned, for tardive dyskinesia, it does not get treated the same as an acute dystonia, as those Parkinson-like side effects. So again, you want to avoid anticholinergics. That would actually end up making it worse for those patients. But most of the time, they'll either discontinue treatment, switch over to something else, namely a second-generation agent, and that will help to mitigate some of those effects, right? A lot of times it's irreversible, so if we can prevent it in the first place, that's going to be better for your patients. If you had NMS that was developing, obviously discontinue the offending agent. That would be the first thing you want to do. Cool the patient is going to be another big thing to deal with that hyperthermia, because again, that can fry the brain after a period of time. Their temperature's up to 106, 107. So you can use things like cold saline. You can use evaporative cooling, where you kind of spray them down, put a fan on them, all kinds of stuff. Ice packs on the groin, the axilla. All that can be very useful. And then we use a drug called dantrolene. And dantrolene will come up when we talk about surgery stuff, when we talk about malignant hyperthermia. This is a drug that works as a peripheral muscle relaxant that will actually help to relax that lead pipe rigidity. And so every hospital you're into, every OR you go to is going to have access to a malignant hyperthermia cart that will contain a large amount of dantrolene in it. And so that's the drug that's available. So every hospital should have this, because another risk for having malignant hyperthermia is general anesthetics. A lot of the inhaled anesthetics can do this, so you have to have that available. The other thing you could do is to deal with kind of the baseline problem and use something that is a dopamine receptor agonist. So you could use something like bromocriptine that would directly agonize those receptors and get that activity back up. This is a good slide to kind of go and look at the different reactions you can have with first generation agents and how where you might see it actually occurring here, and some of the risk factors and the proposed mechanism in treatment there. So that can be useful for study purposes. But this stuff comes up quite often. Like for instance, my wife, she did her second year residency in pain management at the VA in Gainesville, and she's a pharmacist as well. I don't know if I never mentioned that, but she's a pharmacist, did her residency in pain management, and so she does a lot with palliative care patients, right? And how long are palliative care patients usually sticking around for? Not long, right? Relatively speaking, maybe 6 months, maybe a lot less than that. And so some of the things that they were looking at, one of these patients, they wanted to use haloperidol for I can't remember what specific symptoms they're having. They decided to use haloperidol, but the resident was like, oh, I don't want to give that to this patient because I worry about the tardive dyskinesia. And so that was a good education point to say, well, actually, you don't have to worry about tardive dyskinesia. This person's not going to be alive long enough to experience that. However, if we can improve their quality of life by treating some of these other symptoms with using something like haloperidol, that's okay, right? So again, take each individual patient factor into mind, know when these things are likely to occur, so that way you can kind of be more intelligent when you're speaking about things like, okay, well, tardive dyskinesia is a long-term thing versus acute dystonias. That can be a very early sort of manifestation of some of these effects here, right? So moving into the second generation agents, these are also known as our atypical antipsychotics. You're going to find these used a lot, not just for schizophrenia. These we're starting to see these being used for things like treatment-resistant depression. We're starting to see these used for things like ADHD. We're starting to see them used for bipolar disorder. I've kind of alluded to this already in previous section of this, where you said add on a second generation antipsychotic. So has anyone heard of like Abilify? Anyone heard of Seroquel? These are very common atypical antipsychotics that, again, are used for lots of other things. Okay, so we'll see some of those examples here in a minute. Now, Now, the mechanism is a little bit different here. The main thing they're going to be doing is blocking those serotonin receptors that were up in the frontal cortex, okay? So that's going to be important because this means that we're going to have less dopamine blockade. It still has a little bit. So you're still, there's still a chance you can see things like acute dystonias and extrapyramidal side effects, but it's much less prolactin levels. And so you find that they're also much better for the negative and cognitive symptoms. They're okay for treating the positive symptoms, but not as potent as the first generation agents would be. But less tardive dyskinesia, again, not zero risk, but very low risk for the most part. And these need to be first line for these patients unless otherwise contraindicated. Okay. Now, some people may fail these and have to switch over to a first generation, but in general, start with these and kind of go with them. So I mentioned less affinity for D2 receptors in that striatal tract. However, they're going to block these 5-HT2 receptors. And by blocking those, this will help to stimulate that dopamine release in that frontal cortex, and that will allow for more relief of those negative symptoms and those cognitive effects. So we can look at this. If I block these receptors here, these 5-HT2 receptors, because this again has an inhibitory effect. You see that negative sign there. By inhibiting this receptor, you're going to have more dopamine release. And so you have more dopamine activity up here on these D3 and D4 receptors. That helps with the negative symptoms. However, the other thing that happens here as well is they actually find these kind of neuronal circuits that occur with this kind of bottom. Sorry, my pointer's not working. Anywho, that bottom neuron right there that's kind of projecting back to the nucleus accumbens, that actually has an inhibitory effect. So that means that if I have more dopamine activity on that neuron there, you'll actually find it will inhibit back in the nucleus accumbens dopamine release from that neuron, which again we saw was a big cause for the positive symptoms. So you can kind of see how it kind of feeds back in order to help with the positive symptoms as well as dealing with the negative symptoms. So you kind of get a better spread of activity here for dealing with the different components of schizophrenia, which is a benefit. I hate these pictures so bad. It's usually pictures that get added in. I don't know why that is. And it's only with you guys. It doesn't happen in my other charts. My other classes, no, I don't really see this issue with. So it's not the helicopter; it's the pictures. I'll catch back up. Is everyone with me so far? So you see, there's lots of commercials I find now for like Abilify. I don't watch cable usually, but whenever I go to my parents' house, I always end up seeing like a ton of drug commercials, and I see a lot for Abilify. They go, yeah, I use it for add-on for depression. You can use it for this, for that. Lots of use for it. Well, do you guys want to go on your 10-minute break, and we'll come back and continue on? All right, so 8:48. This is the last picture, so we should be good from here on out. What's up?
The last time I bother you about this, I
The
promise.
last time?
Okay. So because I still am not an expert on oral suspension,
That's okay.
prescription
No
writing,
one's meant to be an expert at this point.
this is what I think I want to write.
Okay.
But this goes for all of them too. So since this would most likely be like long term, but I would want the patient to follow up with me, like after like a certain amount of time to make sure that the effects. Do I need to put like for 1 week or?
You would just do that based on how much you're writing for the quantity, and then any refills. So if you wanted them to be on it for a month, then write no refills, right? If you wanted to be on
I definitely
for,
wouldn't want refills, but so I should like just do the math to see how many I would get out of this bottle, pretty much, and say that amount of time.
Yeah, basically.
Okay, and then you would assume that like they're gonna follow up with me and.
Well, yeah. So the pharmacist might question. They may say like, well, how come you only wrote for like 2 weeks worth?
Okay.
And then you'd say, because that would be typical.
Right.
Most people would end up writing for like a month's worth, and then you just give them instructions. Hey, come back in 2 weeks, right?
Okay. So do you suggest that?
You're the prescriber, right? So as long as it makes sense.
Okay. Well, okay.
So right. So if you wrote for like 2 weeks worth, and then you had like 10 refills on there, like that wouldn't make any sense, right? Because like. Then the patients have to come back every single 2 weeks.
Okay.
However, if you...
I should just make sure they match up, whatever.
Exactly, yeah.
But is this what I write in the place of when I would say like number 30 pills or whatever? Do I just need
to
say
so you write quantity and you say how many ever mLs you want to dispense.
Okay, like so 1 bottle worth. But I would say like blah blah bottle.
You don't have to say bottle necessarily. You would just... Okay, so going back to the side effects for the second generation agents, weight gain's a huge thing here, right? Quite literally. You're going to find that, especially with olanzapine and clozapine, we'll get to the specific agents in a second here, but weight gain is huge. You can have patients who will put on 30, 40, 50 pounds on these medications, no problem. And sometimes these are only medications that work for them, which is unfortunate, right? So I think olanzapine, think clozapine as being the two big ones that cause a large amount of weight gain, okay? You will find a lot lower risk for this with things like ziprasidone and aripiprazole. I'll give you a table to show you these comparisons in a minute here. So those are generally a lot safer ones to go with early on because, again, when you add on tons of weight, what other kind of metabolic issues do you run into? Yeah, glucose intolerance. You can sometimes this will put someone into diabetes, right? So make someone a diabetic or worsen their diabetes. What else do you think you can see? Hyperlipidemia can be associated with this. What do you think blood pressure does? Probably going to increase, right? So again, you see all these metabolic conditions are happening from this. But again, if it keeps them from having the symptoms that were really kind of affecting their quality of life before, then sometimes you can treat through that, right? You can do things like dietary modifications. You can do things to help with that. So again, try to pick the drug that's going to have the least amount of metabolic side effects for your patient. But sometimes people got to be on olanzapine. Like some people just only respond well to that drug, and so it's something you have to treat around. Okay. Clozapine you really don't want to use unless it's a very treatment refractory sort of patient because of this risk for agranulocytosis, about a 1% risk for it occurring, which is serious enough that you need to do things like monitoring CBCs every week, right? And so again, these are patients who are compliance is a big issue anyway, so they're less likely to come in every single week for these sort of checks. So you don't want to use this too commonly, and actually it requires a registry program similar to like Accutane did, right? That RIMS program we mentioned. So pharmacist, provider, patient all has to be registered to make sure that they're doing these checks appropriately. Other general things you're going to find, they can cause QT prolongation, so be watchful for that, and they will cause some orthostatic hypotension, especially when you see like big doses given IV, IM, that's more likely to see it. And then obviously elderly patients are going to be more at risk for this. So tolerance does develop over time, but if you can give these ones like say maybe at nighttime, that can help because they're going to be pretty sedating anyway, so that can help them kind of get through the night. It shouldn't be getting up too often and should help them mitigate some of that fall risk. Okay. They do have a black box warning, so one of the things you can find, anyone heard of the term sundowning? What is that? Yeah, dementia is kind of this dementia that happens, especially like you think elderly patients, like you think grandpa goes to the hospital, he's in an unfamiliar situation, setting, sun goes down, and for whatever reason their mental status just kind of goes out the window essentially. They get very, very demented, they can become very difficult to manage. They've actually found increased mortality in these elderly patients and treating elderly related dementia with these antipsychotics, increased mortality, so you want to avoid those for those patients. It's really not the best way to handle those patients. I mentioned sedation is going to be a big one, like I mentioned, clozapine, olanzapine, quetiapine, which is Seroquel. So again, if you can dose it at nighttime, that'll generally help to mitigate some of the sedating effects when they wake up in the morning. They'll generally have anticholinergic activity as well, so you see this manifesting something like dry mouth, constipation. Be watchful for that. And then some of these can lower your risk for, or lower your threshold for having a seizure, and namely olanzapine and clozapine. So again, if you had to start off with the second generation antipsychotic, definitely not clozapine. Definitely reserve that for people who failed everything else, and probably olanzapine is probably going to be a second or third line kind of choice due to the increased side effects associated with it. So generally you're going to find that the interactions are going to be more pharmacodynamic, meaning if you add on other sedative sort of medications that can worsen the sedation, if you add on other medications that can affect the orthostatic hypotension like antihypertensives, that will worsen that as well, so just watch out for that. And then if you add on with other dopamine blockers, you do increase your risk for having extrapyramidal side effects. So imagine metoclopramide or Reglan we mentioned as an antiemetic drug, also promethazine, which we use for what? Yeah, we also use it for an antiemetic because, again, anticholinergic activity is good for nausea, vomiting. Antidopamine is good for nausea, vomiting as well, which is why we use these. And actually, these are kind of all within kind of the, if you look at the kind of the structural hierarchy of these drugs, you find that like promethazine and metoclopramide kind of fall into that first generation sort of category even. So very similar structurally, which is why there's a lot of bleed over of those effects. So again, the big ones I would focus on from this slide, this kind of lists a lot of the, and there's a lot of new ones that are always coming out for these because they're realizing that there's a lot of benefit for treating kind of other disease states than just schizophrenia, right? So we mentioned depression, we mentioned ADHD. So there's a lot of kind of Me Too drugs that are being added on. The big ones you're going to run into most commonly so far are going to be things like aripiprazole or Abilify. You're running into, we mentioned clozapine, clozaril is one to avoid generally, but no, be familiar with that one. Risperidone, I'm sorry, where's that? There's ziprasidone or Geodon. That's another common one we use. This is a good one that you can use IM. So as an alternative to Haldol, you could use this one. We use it in the ERs quite frequently for some of our more agitated patients. So that's another good one you can use. Olanzapine is like Proxil we mentioned from the side effect standpoint of like increased weight gain and all of that. Quetiapine and Seroquel is a very common one you'll see being used, and then Risperdal or Risperidone. So those are the big ones I'd kind of focus on: Risperidone, Quetiapine, Olanzapine, ziprasidone, clozapine, and aripiprazole. Okay, the rest of these other ones are newer ones. You'll still see them being used out there, but those are the ones we had the most kind of experience with so far. You can kind of compare their side effects. Obviously, clozapine and olanzapine are going to have kind of the worst from the metabolic standpoint, but you will see that relatively low on the EPS standpoint, but you will see lots of somnolence with these. You're going to see some anticholinergic effects like tachycardia. So just kind of be familiar with kind of the general side effects of these medications and like unique things to be aware of, like, you know, agranulocytosis for clozapine. That's a good thing to kind of keep in the back of your mind. Just some other new ones you might find. You know, I'm pretty unlikely to put these on a test just because they are so new and we don't have a lot of experience with them, but the ones I mentioned before definitely are going to be fair game. But things like brexpiprazole, iloperidone, you know, these are all going to be ones you're going to find they're being used out there. Kind of similar to the ACE inhibitors, where like they came out with a few of them, they saw that the chance for a blockbuster drug, so lots of other companies come out with new ones. This is kind of the same thing happening here nowadays. And again, you can compare the side effects of the atypicals. And again, these are the kind of the ones already mentioned in the last slide as being the big ones to be familiar with. You can kind of compare the side effects with the first generation agents. But you guys look at that. So as far as monitoring goes, obviously monitor their weight, blood pressure, glucose, their lipids, and then have them be educated on, you know, the different, you know, things like EPS to look for, you know, because again, they may not be aware that it's related to the medication. If you don't get that feedback, you may not know to do things like change the dose or change the drug, whatever happens to be. So make sure you educate them on side effects. Now, if you're dealing with an acute initial management for these patients, if they're having these kind of acute sort of psychotic episodes, they're acutely agitated, you need to treat that as kind of like a medical emergency in a lot of cases. And so the main goal there is to decrease the positive symptoms first. And so you can use things like benzodiazepines to help calm them down. We can use things like intramuscular haloperidol or intramuscular ziprasidone or Geodon to try to get them kind of sedate, help deal with those positive symptoms, and that will get them kind of at a baseline where we can kind of work from there. And generally, you can titrate, based on the efficacy, and then also on the side effect profile to see how they're going to tolerate these medications. And if you don't really see any improvement in 3 to 4 weeks, you probably should decide to switch over to something else because the positive symptoms should be managed by then at that point. Now, patients with compliance issues, this is where you can consider like a long-acting form. So now there's a lot of new ones from a second-generation standpoint that are available. So again, these are usually, compounded in oils, kind of medium, where they would get injected into the muscle and slowly release over the course of several months. Should you start with these ever? Intramuscular kind of long-acting form? Why not? Yep, exactly. So you don't know how they're going to react to it, and once it's there, you cannot take it out, right? So it's one of those things where you could transition a patient over to this if you know they're going to have compliance issues, but otherwise you need to start with oral medications typically for kind of more long-term maintenance, just initially, and then they can switch over potentially. So again, looking at these kind of the stages of schizophrenia, you can base your treatment. Again, essentially, you're going to start with a second-generation agent, aripiprazole, risperidone, ziprasidone. These are all good ones to start out with from the atypical selection for usually treatment-naive patients. In a lot of cases, you're starting with one of these. And again, it's just a stepwise approach. You see how they respond to it. If they don't respond well, then you can switch over to a different second generation. If they're still failing that, then you consider switching back over to something like a first generation. See how they respond to it. And generally, avoid clozapine unless they've kind of failed multiple courses of other things, because again, they're going to have some pretty intensive monitoring to look for agranulocytosis that happens there. Because again, one in 100 people are going to have that, so it's common enough where you need to be concerned about that. Okay. If you're going to discontinue therapy, you need to do it over 2 weeks or more, because you worry about kind of rebound of those positive symptoms. Watch out for that. And then if you're going to switch agents, make sure you taper down off one and then start to titrate up on the other. You don't want to have an immediate discontinuation and starting a new one, because you can run into some side effects with those medications. Okay. Just some of the withdrawal symptoms you can run into, things like insomnia, nightmares, etc. So just be careful with that. Of course, if they, become non-compliant, they stop the medication themselves. Again, they can have these manifestations come up, and then guess what? Now they're having kind of an acute episode. Now they're going to come back to the ER. So this is oftentimes what will happen. They'll go off their meds, they have these rebound effects, and then they end up coming back to see us. So it's an unfortunate kind of cycle that happens with these patients. Because again, once they start to feel better, they think, okay, well, I don't need the medication anymore. They come off of it. But in a lot of cases, they need to be on this stuff for a lifetime. Okay, so any questions on schizophrenia? This is actually a poor representation of schizophrenia. Split personality disorder is a totally different thing. However, there's a common classification there. Anywho, all right, so we're going to continue on, try to finish out the rest of this section with our anxiolytics. We're going to chill you out, and then we're going to get you more pepped up with our ADHD meds in the end. Okay, that work for you guys? Okay, so there's lots of anxiety disorders out there. Did I tell you I was diagnosed with OCD once? So bad OCD? Yeah, okay. Just want to make sure. I know I repeat jokes sometimes, but also selective short-term memory loss. So it's another problem I have. Did I tell you about I got diagnosed with OCD one time? All right. Anyway, we'll lump a lot of these together. There's going to be certain types of anxiety we'll kind of break out. Usually like situational-based anxiety. Anyone know like an example of like a situational-based anxiety? Test. Good too. Test. Public speaking's a big one, right? Obviously with some people you kind of get used to it, but I remember back when I was in pharmacy school and we had a class called pharmacotherapy. I probably mentioned this story before, but you get called on basically, and you're in a room with your cohort of students, you get stand up and they basically will grill you on questions back and forth for 5-10 minutes, and so very nerve-wracking as you might imagine, because you're sitting there going like, okay, do I have all the parts of this guideline memorized and all that? And some people they were popping their propranolol, they were getting performance enhancing drugs, and I was very upset about that, but I got over it eventually. But it's a good learning experience. But yeah, certainly situational anxiety is going to be a big thing. We'll talk about that a little bit separately because the management is different. However, a lot of these can be kind of all lumped together as far as like management of that anxiety. And the two big things you're going to see, there's acute manifestations of anxiety. We'll treat that one way, and then there's more kind of long-term maintenance therapy to help prevent some of these attacks from occurring. So it'll be important to distinguish between that treatment, similar to how with like neurology, with dealing with migraines, dealing with an acute migraine is very different from the prophylaxis thereof, right? So you can kind of keep those distinctions in mind. So, some people feel that there's probably a maladaptive response happening here, and it usually involves norepinephrine and serotonin, probably some GABA as well. And we're going to see that the drugs we're going to use mainly are going to target these different neurotransmitters. And that makes sense because a lot of anxiety goes hand in hand with depression. Like usually you won't find one person has one or the other. It's usually going to be both to some degree. And so we're going to find that our main source of treatment for this is going to be our antidepressants for the most part. So there's lots of drugs that can induce anxiety, so that's an important thing to remember when evaluating a patient. Is like maybe this is medication related. So if they have antipsychotics on board, the akathisia can manifest itself as anxiety. Things like stimulants and sympathomimetics. So things like Sudafed, if they got too much of that, or a lot of ADHD meds we'll talk about. Hallucinogens. Anyone know any good hallucinogens? LSD is a good one. Magic mushrooms specifically, not just any mushroom. There's a lot of dangerous ones out. Yeah, magic mushrooms. Psilocybin. It's the colloquial term for them. That's what they call them. Just go look up some documentaries. I wouldn't suggest any personal use, but go look that up. Anywho, but you can also have withdrawal from certain things can actually induce anxiety as well. So think about people who are on depressants chronically. When they come off of those, they will also have kind of rebound anxiety. So like ETOH or ethanol, opioids, benzodiazepines, they can all cause kind of rebound anxiety. So be familiar with that as well as being a possible cause for that. Because again, treatment is going to differ based on what happens to be the cause. If it's because they have on an antipsychotic, maybe discontinuation is the best treatment for them rather than get them on another medication altogether. If they're on LSD and they're having a bad trip, chances are just don't do any more LSD and that'll fix your issue, right? Anyone ever heard of ayahuasca? It's a really cool hallucinogen. The main hallucinogen is called DMT or dimethyltryptamine. There's some cool documentaries on Netflix you can check out where these people go down to Peru in different places in the Amazon, and they have these two different plants. And I don't know how they figured this out, but these like medicine men and these tribes, they mix these two different plants together. And what's interesting is the DMT itself, when you ingest that as a tea, your GI tract breaks it up and you can't actually absorb it. It doesn't do anything. However, if you mix it with this other plant that acts as a monoamine oxidase inhibitor, similar to what we talked about with our antidepressants, that actually prevents the breakdown of the drug, and they actually can drink it, absorb it, and have these like crazy religious experiences and this kind of dissociative sort of trips and everything. So it's really, really cool if you check it out. Again, I would not recommend doing it yourselves. However, it's very interesting from a pharmacology standpoint.
Is that like the peyote?
Peyote is different. That's actually comes from a cactus. But you'll see that more like Native American. Certain tribes will use that for religious purposes. But this is more of a typical like South American kind of in the Amazon rainforest sort of things. Like Peru's a big one. So you see a lot of people travel down to Peru to participate in some of these ceremonies. And there's, of course, it's like a big tourism business now. And so for better or for worse. Anywho, I'm off that tangent. Generally, supportive therapy should be first line. So again, if you can kind of get them, some behavioral therapy to try to get them through their anxieties, whatever causes them, that's going to be beneficial for them. However, looking at the drugs, for acute anxiety, we're going to look at our benzodiazepines as our go-to, right? So these are someone having an acute panic attack, acute anxiety, benzos are going to be your go-to drugs. And then for chronic management, our antidepressants are go-to. So it'll be like your SSRIs, your SNRIs are going to be the most common. And then we'll look at a few alternative agents, so buspirone or buspar, and then we'll look at some second-generation antipsychotics, rare, but you may see that being used occasionally, especially like in Abilify, especially if they have depression, they're being used for that as well. So you're going to find that antidepressants are going to be good for both acute and long-term generalized anxiety. So again, not necessary to treat an acute attack, because again, these drugs take time to work, but they're good for kind of preventing the acute attacks from happening here. Any of these will work. A lot of them are used off-label for anxiety purposes, but some of the ones that have actual indications are things like venlafaxine and duloxetine. Which ones are these? What category do they fall into? Those are SNRIs, right? And then you have like paroxetine, escitalopram. Those are SSRIs, obviously. And then imipramine can sometimes be used. That was actually a TCA, a tricyclic antidepressant. Those are not used as commonly due to side effects, as we mentioned in the last class. However, if they're not really responding to any of the SSRIs, SNRIs, they could use that as a backup. Now, we don't really know why they're working specifically. They were thought to maybe help with some of these kind of maladaptive stress pathways. But again, they take the same amount of time to kick in, just like they do for depression. So 4 to 6 weeks before you really see the kind of full effects there. And obviously, the adverse effects don't change at all. So kind of go back and review those in regards to what you might see for these patients. Now, benzos, the way they're going to work, and we've already alluded to these being used for what other condition? Yeah, seizures is the big thing, right? So we use benzodiazepines for acute termination of seizures. Again, those are your first-line drug. If you had a patient coming in with having an active seizure, benzos are the drug to go with. And really, all they're doing is they're helping GABA to work better, right? So these are the GABA channels. You're going to have the benzodiazepines will bind to a specific site, and they will allow GABA to bind more readily, and will allow that channel to open up, and what flows through? Chloride, right? Because chloride is going to hyperpolarize those neurons. So again, they act as kind of a general CNS depressant. You can imagine that will help to deal with those anxiety issues, those acute kind of panic issues that are happening there. So we have a lot of them that are available. I will kind of note a few here just for some unique characteristics. The thing that really differentiates them is not only are they available either orally or IV. I'll kind of note that here in a second, but a lot of them will depend on their kinetics. So you're going to find some of them are going to have hepatic metabolism, some of them are going to be very lipid soluble, some are very water soluble, some of these have active metabolites. So you got to be careful in certain patients to get these, because again, if you cause kind of CNS depression and they can't clear the drug, it's going to lead to too much CNS depression essentially. And who might that be dangerous in? Elderly patients, right? So you guys have mentioned the Beers list, right? A lot of benzos end up on the Beers list because they're very dangerous for elderly patients, because they get very, they're not really able to clear the drug. It sticks around for a while, and they can have risk for falls, deterioration of their mental status, all those sorts of things. So the things we like for elderly patients are going to be water soluble benzos. They don't require a ton of hepatic metabolism, because they have hepatic impairment. They'll have issues clearing it. And they don't have active metabolites. So the 4 big ones we like for elderly patients is going to be the acronym LOT. So you use lorazepam is a good one, oxazepam, temazepam, and then triazolam. Those are the 4 that are good for elderly patients because they are water soluble. They don't have active metabolites. They can get cleared pretty easily from those patients as compared to some of these other ones. Yes, ma'am. Oh, good. Okay. From an IV standpoint, the most common ones you're going to probably run into will be things like Ativan, lorazepam. I'll just kind of circle these just so you're kind of familiar with them. Midazolam and then diazepam are probably the big IV ones you'll see most often. You mentioned like diazepam can also be used what route for seizures? Remember, per rectum, like, so we can use that as a diastat. So again, that would be like an EpiPen someone would have for their seizures. They would take it with them everywhere if they have a seizure. Then a family member or someone could, pull their pants down, insert it, and then insert the drug into the rectum and treat that seizure there. Those are the most common kind of IV ones you'll run into from because, and we'll use these potentially for patients who are presenting to the ER with an acute panic attack. We will give them benzos occasionally to try to help calm them down, to act as an anxiolytic. We use a lot of kids coming into the ER. They get pretty anxious about having needle sticks, right? So if you have to draw labs, if you have to get an IV started for fluids or whatever it happens to be, they get very, very apprehensive about that. And so imagine, I can barely give my kid oral medications without her spitting it back out of me. Getting an IV on some of these kids can be very, very difficult. So if we can give them a little intranasal Versed, chill them out a little bit, and then they can get the IV started, right? So that kind of helps out quite a bit, and we'll use it pretty often. Some other ones, anyone ever heard of alprazolam or Xanax? Anyone know the street name for that? Yeah, Zany bars. You know why they call them Zany bars? Because they come in actual little bars, and actually they look like little Tetris pieces, right? They're kind of the big ones that you're going to stick to get all 5 lines kicked out. They kind of look like that, but they're made so you can kind of break off individual pieces if you only use like a half tab or a quarter tab or something. Yeah, that's why they make them look like that. They got the street name Zany bars, and because again, this is a very common set of medications for people to abuse and buy off the street. So other ones you might run into, clobazam we mentioned is being used for more like kind of long-term maintenance for seizures. You'll see clonazepam being used quite often for that as well. Yeah, so those are kind of the main ones you're going to see. Alprazolam is a very common oral medication used for a lot of patients. And again, you're going to find that with these, you want to use them as infrequently as possible because the longer people are on these medications, what can potentially happen? Yeah, so addiction is a concern, but they get physically dependent on these medications, right? So all of a sudden, they get used to having all this extra GABA effect around, and then when you take that away, just like you see with alcohol withdrawal, things like that, you can have kind of this rebound anxiety, you can have rebound insomnia, you can have seizures potentially in some patients because they have too much glutamate activity, not enough GABA. So you got to be careful with these medications in the long term, okay? Some other question? Yes.
Do they use Versed for, I'm probably mixing something up, intubations?
Occasionally, yeah. So when we're intubating a patient, you normally have to give them some sort of sedative, and then you have to give them some sort of paralytic. So usually there's a whole cornucopia of drugs, and I have a whole section on that. May talk about that different drugs you can use for RSI or rapid sequence intubation, but sometimes people use Versed. It's not a great drug for that. There's other better drugs we have, but some people will still use it.
So is that for like the sedation?
It's part of the sedation, yeah. Because these are sedative medications. One of the things you also see, anyone ever have or familiar with like brownouts and blackouts associated with alcohol consumption, right? You have some of that amnesia that happens there. Same thing happened with these drugs, which can be beneficial if you don't want your patient to remember the fact they got intubated, right? You can have some of that kind of retrograde amnesia, and some anterograde amnesia that happens there, where they will kind of forget about kind of the preceding events, and then they wake up later on and don't really remember it all, which can be beneficial for some. But we'll use these as a muscle relaxant. We use it for sedation, acute agitation. Lots of uses for benzodiazepines. Remember, these are all controlled substances. They're all C4s. So again, that is also another concern if you are prescribing someone who has a history of substance abuse or things like that. Be concerned with that. Now, we mentioned the kinetics differ wildly based on the different medications, but just remember that LOTT that I mentioned being the most common ones we'll use, or the most preferred ones for elderly patients, due to the fact they avoid a lot of those active metabolites. They are more water soluble, more likely to be eliminated without too much of an issue for those patients. And I mentioned the IV versus PO. A lot of them are available PO you're going to run into, and this is the most common one you're going to be prescribing for your patients, especially for anxiety purposes. We may, like I said, some of our neurologists will prescribe Diastat for seizures. That's per rectum. Sometimes we'll actually do some intranasal. We'll give the patients the syringe and the atomizer to do that. So it just depends on the patient, but most of them are going to be used PO from the kind of the outpatient standpoint. And then some of these are also metabolized by CYP3A4, so you got to monitor for those kind of interactions as well. So just remember that being a possible drug interaction there. Okay, so again, side effects from a dynamic standpoint, mainly CNS depression. You will see tolerance develop to a lot of this, so this is definitely something where, the first time they take the medication, I would not want them driving at all, but some people do develop enough tolerance to where they will be less impaired. So that is, not to say that we want them to get to that point, because we want to use these pretty infrequently. This should not be an every single day sort of medication unless they're taking it, for prevention of seizures, which those patients usually are not going to be driving in the first place. However, other things you can potentially see, obviously there's some synergism with other depressants, especially alcohol, especially opioids, so be careful with that, because if I get too much of these on board with these other CNS depressants, you can potentially see respiratory depression, they can vomit while they're passed out, and they can aspirate, so there's lots of issues that develop from that. And I mentioned withdrawal, you want to avoid that. You need to titrate off these drugs slowly to avoid that rebound sort of effect, which can be fatal for benzos because you can have that rebound seizures that can happen there, so you got to be really careful with these drugs. Okay. Next we have buspirone or Buspar. This is actually a non-benzo anxiolytic. It's a non-controlled substance, which is nice from that standpoint. However, it's probably not going to be as effective as you'll see with your antidepressants. However, it is an alternative you can try for them. It's usually second line for generalized anxiety disorder, mainly due to the kind of questionable efficacy compared to a lot of your antidepressants. It still takes a few weeks to kick in, so it would not be good for an acute panic attack like a benzodiazepine would, right? We don't know the full mechanism. Probably has to do with serotonin antagonism. And again, it's pretty well tolerated, not a ton of side effects associated with it. And watch out for 3A4 interactions there. But again, some people do really well in Buspar. I don't see a ton of use, however, compared to using the antidepressants. It's really kind of replaced Buspar's use for the most part. And then beta blockers. So beta blockers are going to be uniquely used for situational anxiety. So if I got really nervous before coming up and talking to you guys, I would use a beta blocker potentially. Now, do the beta blockers actually do anything to the anxiety that the person's feeling? No. What does it do for me though? Yeah, it blocks those physical manifestations, right? So again, if I am, because when you're in a anxiety kind of prone state, which nervous system is activated? Sympathetic, right? Your fight or flight response. I'm getting up here, I'm shaking, I'm sweating, I'm talking fast. I do that anyway, but you have all these different manifestations of the sympathetic nervous system. I can block a lot of that with the beta blockers, right? So usually propranolol is a very common one being used. The big thing to remember with these, you want them to test it out beforehand, right? You don't want them to use it the day of their event, and usually an hour before. Okay, not right when they're about to do the presentation, because then that will mean that the drug is still absorbing before and they'll be over before the drug kicks in. Do an hour before, use a test dose beforehand because you want to see how they're going to react to it. Now, any beta blocker can be used. So for instance, they had asthma. I don't want to use propranolol, but what could I use? Before N, right? You want A through M, right? So atenolol is good, metoprolol will be fine. Any of those would be good options if you had someone who, let's say, they reactive airway disease. Now, you can use it for things like, music performances, public speaking. However, think about the fact that beta blockers will induce exercise intolerance, right? Because you're blocking those beta receptors potentially on the heart that are going to be necessary if it, say, is like an athlete, right? So if I'm going to go and, have, the quarterback or something, you may not want them to be on a beta blocker if they need to be physically active. So that's one thing to consider is the kind of physical impairments that can happen there. But if it's like a public speaking thing, beta blocker is really good for that option, right? So again, urgent symptoms, if they're not having them, SSRI, SNR, you can get them started out with. Otherwise, something like a short course of benzos, you may see that you may just give them like a week or two worth of benzodiazepines to kind of get them over the hump until the SSRI start to kick in. That's totally fine, but generally you want to hold off and use them as infrequently as possible. However, some people will just get to that point where they're taking them every single day and they get very tolerant, very dependent on those effects. Again, if they don't have adequate response, just similar to depression, if they don't respond to one, they may respond to a different one. There's a lot of interpatient variability there, so you just try switching around. And then if there's still no adequate response, then you can consider TCA. But again, remember the side effects associated with those. Okay. Any questions on anxiety? All right, now moving on. Our last thing we'll talk about here for behavioral is attention deficit hyperactivity disorder. So, what do we use to treat this? Adderall? What is Adderall? I'll just say alcohol. I was like, I probably wouldn't treat it very well. But you definitely would not be hyperactive if you drink enough. But so what is Adderall? Amphetamines, right? Amphetamines. We are giving these people amphetamines, right? This is very similar to a lot of illicit substances. And so one of the big things you're going to run into with these drugs is that they will be abused, right? So again, is everyone who's taking Adderall on Adderall, do they have a prescription for that? No, a lot of people will buy this from other people, especially like in schools. You can see this kind of rampantly where a lot of people get a prescription, they get the diagnosis. Again, do we have a test to absolutely confirm they have ADHD? It's all based off symptoms, right? So again, you can fake it and you can get a prescription for this and they can sell it out to other people. So be careful with that. A lot of people may be on amphetamines you don't actually realize are on them, and that can be important when we talk about side effects and whatnot. Now, from a controlled substance standpoint, do you know what schedule these amphetamines are going to be? These are 2, right? So they're going to be the highest control we can have on these drugs, and so that'll be important when you're thinking about things like how much they can get refills for, right? Can you do a refill on a C2 script? Cannot do it, right? So they have to come back and they have to have different scripts. You can write up to 90 days worth, right? So you can write 3 different scripts, and I see that a lot where, especially at pediatrician's office when for these kids are in school, they'll write for, 3 different scripts, 30 days each, and they'll write don't fill until, this, on the second one they'll say don't fill until this date, and the third one they'll do don't fill until this date, which is another month out. Okay, so that is a thing you can do with these scripts potentially. So anyway, so again, the big thing with these drugs, you want to identify a goal. Do you just want them to be able to sit in their chair for 20 minutes? Do you want them to be able to complete their homework? The other thing you have to consider is, a lot of these kids who were originally diagnosed with ADHD, they're adults now. Also, there's a lot more adults being diagnosed with adult onset ADHD. Plus or minus, who knows, but there's a lot of people who are going to be on these medications, and so it's important to be kind of familiar with them. Obviously, if we can have some behavioral interventions, things like that, non-pharmacologic help, that is going to be the best, because again, these drugs are not completely innocuous. There is definitely risk for abuse and dependence that develops with these addiction along with that. So stimulants are going to be our first line. The amphetamines that we're using kind of have multiple mechanisms, but their main goal is to increase release of norepinephrine, increase some levels of serotonin as well, but they will block monoamine oxidase. They're increasing catecholamine levels. They also will block reuptake of dopamine and norepinephrine. Now we mentioned what is really important to that reward pathway. What neurotransmitter do we see being used? Dopamine, right? Those dopamine squirts you talk about when you gamble and you win, or you eat a big juicy hamburger. That dopamine is really important for that reward pathway. That's where the addiction comes from. So by blocking the reuptake of dopamine, you can see how these medications can be abused and kind of stimulate that pathway, and you can see addiction develop here. This is why these are as abuse-ridden as they are. And so again, these are the main mechanisms they're using to increase the norepinephrine, but also secondary to that is dopamine. Now, you're going to find that, again, there's interpatient variability here. So just because someone fails something like dexmethylphenidate, they can try dextroamphetamine, they may respond better to it. And there's lots of different formulations. There's IR formulation, there's controlled release formulations, there's patches, all kinds of things are available for different types of patients. Okay, what's the benefit of using an extended release prep? Yeah, so you can give it to your kid before they go off to school, and then they don't have to get another dose until, say, they come home in the afternoon or at all, right? As opposed to having them get it, a kid carrying around a C2 med, like, it doesn't sound like a good idea. But them have to get it, usually the nurses will have to hold on to it at school, and they get 2 or 3 times a day. It's a hassle. Controlled release preparations are generally good for most patients. And again, when do you typically want to take these medications? In the morning, typically, right? Because if you take them at nighttime, guess what? You're going to be on speed at night, and you're going to be wired, right? So that's usually not a good thing. So the big common ones you're going to run into include methylphenidate, and again, there's tons of different brand names that are out there. So for instance, there's Ritalin, Metadate, Concerta, Quilivin. There's not a lot of difference between a lot of these besides their release characteristics and whatnot. There's also a Daytrana patch that's available, so again, can be good for some patients. This is not one that you would leave on for like a week at a time, like some other ones. It would be like stick it on in the morning, take it off when they come home from school, whatever it happens to be. Dexmethylphenidate's another common one, and then when you see Adderall, it's usually a mixture of different amphetamine salts, like amphetamine and dextroamphetamine is a common combination you see with that one. Anyone ever heard of Vyvanse? This is what I'm seeing much more commonly nowadays, being very commonly used for a lot of kids. At least when I was working in the outpatient pharmacy at Nemours, we see this a ton of Vyvanse. This one's actually kind of interesting because the parent drug itself is inactive. And so one of the things you'll find with these drugs, especially the controlled release preparations, is that you recommend do not chew or crush them. Okay? Why do you think they recommend that?
It's not effective until it hits the liver.
Well, most of these are oral medications, except for the patch. But if I have a controlled release preparation that's meant to slowly release drug throughout the day, and I crush that, you break the controlled release, right? You get all that drug at once, okay? Some people will do that on purpose, and then they can do things like I can now inject it. If I solubilize it, I can now snort the drug. And so that was a big risk for abuse with these medications. And so what they decided to do with the lisdexamphetamine or Vyvanse is that they made the drug a prodrug. We mentioned prodrugs themselves are inactive at first and requires activation by the liver. So if I take this drug normally, orally, it will go to the liver, get activated, gets turned into dextroamphetamine, and then I'm good to go, right? However, if I were to say crush this up and snort it, it would bypass the liver for the most part. You lose a lot at first pass, and you don't really get as much of a high from it. So that was kind of designed as an abuse deterrent. But I see it used being, it's still a very effective amphetamine being used for lots of patients. So you definitely see that one being used quite often. As I mentioned, C2, does that make sense for the abuse deterrent? Yeah. Do you have a question? What's that?
I understand what's being released and the chemical reaction that's happening, but I'm still still lost at how an amphetamine helps someone who's hyperactive?
That's a really good question, because you think that it seems counterintuitive, right? It's like giving someone who's depressed more alcohol, right? Usually it doesn't seem like a good idea. I guess the goal is try to kind of rebalance out those pathways, that, like, especially that norepinephrine, those catecholamine pathways, to try to get them, instead of being so kind of, their attention being so kind of divided, try to focus it in on kind of one thing. Because the problem is, if you give this to someone who does not have ADHD, what happens? Anyone know? I'll never forget. I had one friend who in college we had this A&P lab final. I've ever told the story. So all right, so I was an undergrad. It was probably our second year undergrad or so, and we had this A&P 2 lab, and it was the one where we dissect the cat throughout the whole semester. And so the lab final was coming up, and they basically were just dead cats everywhere in the room. You had to go through and identify all the different parts on it. Right? Sounds like a nightmare. It was. It smelled terrible. However, my friend who was taking it with me, was like an 8 o'clock lab that the morning, so it was a very early class, and my friend who had recently met a girl, as you do in undergrad, decided he was going to hang out with her and then not study like he was supposed to until probably like midnight that night, okay? And so he was very tired, and so he's like, oh, well, someone's got half an Adderall I can take. And so he did not have ADHD, took this half an Adderall, and he was kind of a little guy anyway, so the dose was probably kind of big for him. But he showed up at my door the next morning, 7:45 or whatever, and he's like, hey, all right, let's go. We got to go to the lab final, do this. I'm just like, are you okay? Like, what's up, man? And he's like, oh, took half an Adderall. Oh, I'm good. Let's go. Let's study. And we're walking along, and we like kind of cover like, what is this? What is this? And he just flight of thoughts. I could not concentrate on more than one thing for any 5 seconds at a time, right? And so by the time he got into, this lab final, where basically had to go through and like very detail oriented, go through and look at this cat and try to identify which muscle is this, which organ is this. He couldn't do it. He ended up bombing the whole thing. Had to take the lab over again. Okay, right. So you find. Right, so you find for someone who doesn't really have ADHD, they can get to the point where it almost seems like they have it, because they get very overstimulated, essentially. But for whatever reason, again, I don't have the full mechanism, I don't think anyone really knows entirely, but you kind of get them hyper-focused and allow them to kind of better use their attention towards one thing at a time, essentially. That's kind of how I think about it, at least. But again, I don't have the full answer. This is how I kind of rationalize in my head. It seems to work, though, right?
That's a bummer.
Anywho.
Right,
and
what you're balancing out.
Exactly. We don't really know. Just like with depression, we don't know why antidepressants really work. They just know they kind of work. Yeah, exactly. One of those things. Which will be. But we'll look at some of the other drugs we use, the non-stimulants. We'll see they work via totally different mechanisms in just a second here. But the stimulants, as you might imagine, a lot of weight loss medications are based off of stimulants. You'll see definitely some issues of reduced appetite, weight loss associated with this, which may not be good for young, growing children, right? So you can see things like growth stunting that can occur with this. Insomnia, especially if they're taking too close to bedtime, things like that. Tachycardia, hypertension. So be careful, especially with adult patients who have things like hypertension already. This can worsen that, okay? The other thing to be careful of, these black box warning for psychotic episodes, hallucinations that can occur. They've seen that with, usually you kind of see it towards the beginning of therapy, but it can happen later on. However, the abuse and dependence is a big deal, and so this is some pretty harrowing stories that are out there for kids who will get started on this in elementary school, be on it throughout, all the way throughout school, and then they get to a point where like, okay, well, you're not in school anymore, we're not going to give you anymore, and it's like, well, you can't cut people off like that because they get very dependent on these things, right? And so some people will go into addiction when they kind of don't have that source for the drugs anymore. So we really be very careful with these, especially patients who have a history of substance abuse. These are not the best options for them in a lot of cases, as we'll see. There's some alternatives we can use, which we'll look about in just a second. So, again, be careful with withdrawal. What do you think withdrawal effects from an amphetamine would look like? So just like withdrawal from alcohol, withdrawal from benzodiazepine, they get very kind of hyperactive, they get insomnia, they're very anxious. The opposite happens here. So you're on a stimulant, you withdraw from that, they get very depressed, they don't have a lot of energy, maybe sleep, increased sleeping, things like that. So watch out for those withdrawal effects. And again, they mentioned, this growth stunting is a potential risk in some or in some children. So you want to be careful with that, especially if they're, pre-puberty. And so they will actually do, sometimes they'll do drug-free trials, which kind of makes sense based on the school year. Maybe they don't need it during the summer times. That way they have a couple months where they're not taking the drug, and then school gets back and they may go back on it. So again, they may not need to be on it every single day forever, but you'll have some periods where it's more useful than others. Okay, so some non-stimulant options. You have things like atomoxetine or Strattera. This one's a norepinephrine reuptake inhibitor, so very specifically blocking reuptake of norepinephrine, kind of a unique mechanism compared to your amphetamines. And this is approved for use in adults as well, so this is another common one you'll see. But it does have a slower onset of action. So similar to antidepressants, it takes a few weeks to kick in. However, your amphetamines, they work almost immediately, right? Because again, they're directly causing those dopamine and norepinephrine to increase release. This one's going to take a little bit longer, but it really doesn't have any dopamine activity, so there's really no addiction associated with it, which is good. It's a non-controlled substance, no abuse potential associated with it. You will see some risk very similar to the antidepressants, as we talked about, some risk for suicidal ideation, so you got to be careful with that, some risk for liver injury, and then hypertension, tachycardia related back to that norepinephrine effect. So again, kind of watch out for those issues. But otherwise, it's good if you needed a non-controlled substance for these patients. Now, the other thing you can give are alpha-2 agonists. We've talked about these before, guanfacine and clonidine. You remember kind of what their clinical effects were? How do we use them before?
Hypertension for quantity.
Yep. Guanfacine, we could also use that as well. That's one I kind of mentioned briefly. But remember, by acting on those alpha-2 receptors, you're kind of decreasing the release of norepinephrine from those neurons, right? So we call it sympatholytic because it is decreasing the activity of the sympathetic nervous system, right? So this would make sense this makes more mechanistic sense for me with ADHD because you have someone who's kind of hyperactive. This kind of depresses them a little bit. And so what I oftentimes will see, common combination, they'll be on amphetamines in the morning time, and they'll be on one of these drugs at nighttime. And so especially if they have any insomnia issues from the amphetamines, this will help to kind of bring them down and sedate them because again, from the CNS down, we're kind of decreasing the sympathetic outflow. So that is one thing you'll see occasionally. Guanfacine has an extended release preparation called Intuitive. You'll see, and that's used for ADHD pretty commonly nowadays. These will not be as effective as the stimulants, and they also we're going to see some side effects related to hypotension, sedation. So you got to be watchful for that. Just let them know, hey, this is probably a nighttime medication. Make sure you're taking it then instead of during the daytime. Otherwise, they'll be asleep when they're at school, and that really won't work for them. So obviously therapy is going to be very much individualized for the individual patient, and you need to consider what their schedule is, what kind of adherence they're going to have. Obviously if it's a kid and their medication is being given to them every day, that's going to be a different story than if it's a person taking it themselves. Look at their comorbid conditions, especially with more and more adults being treated with these medications. Think about things like their hypertension. Maybe clonidine is a good option if they have hypertension and ADHD. This may be able to help kind of kill two birds with one stone essentially. So that can be useful, and so consider those things. But generally, start with a stimulant medication. You can switch around between a few of those. And again, this is one of those things where if you're writing prescriptions for it, you may only do it a month at a time and have the patient come back to you because you want to monitor for things like their vital signs. You want to monitor for how, are their grades improving, these different outcomes you're kind of looking for. You talk to the parents to see what how they feel the drug is working. And then once they kind of get stable on something, then you could write for the 3 scripts, a total of 90 days worth essentially. You don't have to come back and see every single time, right? And then some patients may have kind of underlying depression, so sometimes you may get some benefit from having antidepressants on board as well. But generally, start with your stimulants, non-stimulants, and then you can consider other issues that are going on. Okay, so any questions on that? We have a few minutes left. If you guys have any questions about anything we've covered previously, I know you've been studying it diligently every day. So you have all kinds of questions before the test, right? Test is next Friday, correct? Your assignment will be due then. I'll have a whole fun weekend of grading prescriptions. It'll be good fun. I'll have 20 some odd from you guys, and I'll have 63 from my other class. So that'll be a good week. Good week. It's a lot of prescriptions to read through. I'll feel like I'm working at a Walgreens. I'll be going through checking scripts, right? Huh? At least I don't have to fill them. I don't know, maybe get my kids to work as my pharmacy techs and okay, you pour this in the bottle and you do this and count to 30 and yeah. I think so, yeah. It took me a doctorate degree to learn how to count to 30 by 5s. I mean, if I can get them started early, then more power to them, right? Exactly, yeah. Any questions we can answer? So we cover neurology. We cover what's the second? What else do we do?
Parkinson's and stuff.
Yes, all the neurology stuff. We had all of the behavioral stuff.
Chemo.
Chemo, oh, right, chemo, yeah. Think about chemo. Think back to adverse effects. Think about to antidotes for anything. Think about mechanisms. Because again, I'm not going to go into and be like, okay, you have a patient with non-Hodgkin's lymphoma. What are you going to use? It's not really our purview here. However, it will be like a patient's on cisplatin for non-Hodgkin's lymphoma. What are you worried about side effect-wise? What are you worried about from an antidote standpoint? Yeah, ototoxicity, nephrotoxicity, absolutely, right? Throw on cyclophosphamide. What could you give them as an antidote to prevent hemorrhagic cystitis? Mesna, yeah, Mesna is the what do you give for that. So keep those things in mind. You know, kind of use that homework as kind of like or the quiz we had is kind of a guideline for kind of what your things that relevant topics that may come up for those sort of questions, right? The neurology stuff, a lot of it's again focus on, because I'm not going to ask you specifically either. Again, we talked about one specific type of seizure, about absence seizures. Remember, we had one drug of choice for that. Remember, ethosuximide is a drug of choice for that. However, all the other stuff, you know, a lot of them are pulling multiple duties as far as how many different types of seizures they can manage. So we can go back to adverse effects, look at side effect or mechanisms of action, things like that. You know, if a patient was, you know, on phenytoin and that mechanism, you know, they were having okay effects, but you want to add on a different medication, think about someone with a different mechanism, right? So phenytoin being what type of, what channel blocker? Sodium channel blocker, right? So phenytoin sodium channel blocker, maybe add on something that helps with blocking calcium channels or blocking glutamate or helping GABA work better, right? So think about those kind of things to make sense of when you would add on one medication versus another. Because again, you don't want to pull double duty. You usually wouldn't do phenytoin plus carbamazepine because they're kind of doing the same thing, right? Side effects are really big with the anti-epileptics. Watch out for those. Be able to kind of interpret, you know, if a patient comes back with a certain level, and I'll give you the reference range, but they're having side effects or they're having a lot of breakthrough seizures and it looks like the level's okay, what would you do as a kind of secondary step to that, right? Think about things like that. I think anything else? Yeah, it should be pretty straightforward. Any questions in particular you can think of? If not, I'll try to answer them throughout the week, and then we'll be here next Friday and we'll go from there, and then we'll start section 2 afterwards. So, yes, ma'am.
I mean, I know first line things are kind of important, but would there be something that was like, okay, they failed an SSRI, and then I have to go to SNRI, and then I have to go to TCA, and then I have to go to MAI? Like,
Yeah.
that's fine.
It's good to have a general idea of kind of your stepwise approach, but I mean for like depression, some people may start with an SNRI. You know, it just depends, especially if they have like, you know, or look at the comorbid conditions as well. So for instance, if I had a patient diabetic neuropathies, right, and had depression because of that, maybe I could use an SNRI because I know I can use SNRIs for neuropathic pain, right? It's a good, you know, again, 2 birds with 1 stone kind of thing. Look for that. Look for contraindications that may make one type of drug not suitable for a patient. So in the same instance, had someone who had uncontrolled hypertension, maybe an SNRI is not good for them because that norepinephrine can raise your blood pressure, right? Think about things like that. Those are more kind of high level kind of questions I'll ask. You know, certainly I'll have the basic, like, which is the mechanism, you know, which drug has this mechanism, what's the side effect of this. Those are, you know, those are just kind of memorization, regurgitation. Like, but I like the ones where, you know, you have to think a little bit further than that. You have to think about how would I manage this patient, you know. So there'll be a couple of those. All right, now I will see you guys next week.
Yeah.